I wanted to share with you a little bit of a vision that for sure you already have in mind, which is the European Health Data Space time frame that is being published by the European Commission. It's always good to keep in mind the time frame that is intended to be accomplished because, as you know, we are supposed to be here now, and you probably, Apostolos, can talk us later because there was also the TEDAS 2 stakeholder forum that TEDAS actually has as a mandate developing some of these application guidelines on how to implement the EHDS at country level. So, but we should be approximately here. So the entry into force, and then we are developing, we are in this area here, we are developing, you see my point here, my pointer? We are more or less in 2026 trying to develop the guidelines and implementing the different application documents, because first thing deadline for certain implementing acts is by 2027 more or less, and then in 2028 we have already some things to be accomplished, and then we will start with the exchange of the first group of priority categories, and then we will start with the exchange of medical images, and this means that there's a lot of work previously to be accomplished, and that involves for sure the different countries and regions. The data categories that are being, and I'm just pasting here some of the contents that we've also published in our website as a reflection in Biocat, but we just published this on how Catalonia is entering, and this is actually what I'm going to talk a little bit, is entering the health data space. And then we have a very strong capacity on having collected the electronic health records for years, 30 years already of electronic health records, and also very uniquely, but it's not probably just for Catalonia, but it's not quite spread in all regions in Europe. Our primary care and our secondary care or hospital level are connected by the health data. So, or at least the primary care health data are collected in the same strategy. So we have administrative data, we have reimbursement data, and I know, Jose Maria, that you're much more knowledgeable than I am on some of those subjects. So please, after me, you will correct me for sure. But let's discuss. And then the automatic generated personal electronic health data, the wellness applications, etc. And then we have here registries. This is the kind of data that are being used, human genetic and clinical trials data that are in companies. And Annabelle, you are knowledgeable about that as well, on how, to which level the industry also gathered from clinical trials, but also the hospitals and different stakeholders. These are the data categories. But what we've been doing in Preciseu, and I mentioned that at the beginning, that we have been gathering some of the big initiatives and the bottlenecks that we have at different regional and member state level. And to talk about that and to overcome these barriers, we have to understand which are the current assets. And the assets in Catalonia is that we have a system, PADRIS is a framework of the health system data gathering that enables the reuse of the SISCAT, which is the Sistema de Salud de Catalunya, so the Catalonia health system, health data for research, innovation, and evaluation. That is the idea. But so far, and PADRIS was set about 2020, if I'm not wrong, it has been mostly used by public research, by researchers. So now the mandate from EHDS that we have to have access to secondary use or reuse of health data for innovation and for decision making, policy making, it has made take the decision at Aqua's level to reframe or reorientate PADRIS and open a new office called ODAS, the Oficina de Access, the secondary use of data access office, that is going to be at regional level the access body for data that is going to be connected to the Spanish governance level, and then at a European governance level. So that is a very important first step that Catalonia is already taking. And some of the requirements that we have for EHDS is that the health data access body functions when the readiness is necessary, that we have regions and countries have to secure processing environments, that there are data catalogs and metadata well organized, that the governance and the access are transparent, and then that we have to work the privacy ethics, and that's important because we have Laura here later. She's going to talk about that, and citizen trust. And the strategic priority for us now is turn Catalonia's strong real world data, which we already have, infrastructure, into this trusted hub for research, innovation, policy, and personalized medicine. This is the focus of Preciseu, and this is what we've been looking at from our perspective. And then the problem that matters now for us is that this one urgent policy or implementation problem who is affected that we are asking all speakers to provide. And I'm really sorry that Aquas is not here to provide this talk because they have the latest of it. So I can only talk about what we've been observing for Preciseu, is that we are looking at the legal and governance frameworks. We are looking at the data access and the authorization mechanisms. We are looking how environments are secured in the terms of processing, how data quality standards and interoperability are contemplated, and then the operational capacity that the region and the country has. And we have that presented as fact sheets, that are available, are being sent to the European Commission and are available because those are deliverables that are going to be public if they are not yet. For the Preciseu landscape, we were more or less urged to present it as Spain and Catalonia, so we had to jump all the time from comparison from Catalonia to Spain. So, Annabelle, I think this is also very interesting for AstraZeneca at the level of all the different perspectives, for sure. But then we applied from the project this maturity grid model, and we tried to ensure that the analysis was comparable for all regions and member states. And some dimensions were agreed among all partners, aligned with the regulation requirements that we understood were there. And then we found some evidence-based scoring that we helped us see where were the bottlenecks and where were the capacities, and we based always on existing reports and official sources. We also included some assessment and revision by experts in every region. And this maturity grid model allowed us to compare across countries and regions as we expected to. The assessment is based on those reports. Like I mentioned, for example, in our case, we had like a couple of reports already in place because we had previous projects like EDA that already was identifying these needs across different countries. We also prepare for, like I mentioned this morning, every 6 months we change the presidency of the union, and then we perform a case study on every single country that has the presidency at the moment. So we bring that also on board. We also work with TEDAS and TEDAS 2. We got inputs from all regional partners. We do this desk research, and the regions have assessed their own system using the same framework. So probably for some of the experts today, or the experts that are going to be together on the 13th, not all these comments and not all the capacities are there. But so if you have some comment, please tell us there. Other than that, I wanted to share with you the policy architecture that was at Padris, and it is a very interesting, good practice because initially it was kind of highlighted in our study as something unique across Europe. And let's see that, for example, we are, is in Catalan, sorry, but the architecture, because they don't have it in the website, or I didn't find it in the website in English, but it's interesting to see that it all starts with hospitals, primary care, socio-sanitary and mental health addiction pharmacies. Everything is connected, and the people is at the center. But then So everything is put there, like prescriptions, images, reports, medical visits. So these are the in a very secure place, the health data. And then there's these tools of management and planification connected to this. So what we get from here is all the transparency, all the efficiency, all the efficacy, etc., the responsible research, etc. And then AQUAS, which is the agency for the health technology assessment, which is agency for the quality of the assessment of health technologies, has a legal framework and a council in which all these requirements are reviewed. And then in this machinery, requests for use of data arrive, and then there's this vigilancy committee or operative committee. All the experts, all represented, the different stakeholders in these committees support the prioritization, the agreement signature, because it has to be very well traced, and then the extraction and consolidation of the data, and then of course anonymization and everything that has to be in place. But then the research infrastructures, the research institutes that are working with this data are totally identified. The anonymization is in place, and then it can go to research, evaluation, planification, and innovation. Now it's where private users enter into play under the HDS framework. And so Catalonia has very much put in place this machinery for years already. So this is adapting to having this secondary use of data office. So now the research centers of the system, the public research centers and the universities have been using that for translational research. But now this is going to be adapted to the HDS requirements. And of course, all the outputs of this, which is the better research, better healthcare provision, etc., going back again to the system. This whole way of working now, it can have some stalled bottlenecks or places where us with our report have identified. So oh, sorry, because this took too much. Sorry for that. We are not seeing this. Let me just reduce that because you cannot read it down. Here it's better. So yeah, again, I just go back to the presentation. So what we see here is that decentralization, because we cannot operate as a system out of the whole Spanish framework with 17 regions. So this fragmented governance appeared as one of the shortcomings in previous reports we had at Spanish level, and appears again in this report. And this is because there are different speeds at Spanish level also, so we have to catch up with that. We are operating with advanced regional health data infrastructure, but national coordination is complicated. So that is one of the places where the system might stall if we don't look at that as a prioritization. Also, the restriction of the access to health data for secondary use restricted to a limited set of entities in the moment. So that's where why the office others is put in place, just to look for that. And multiple interpretations of GDPR at regional level. So our is one, but then we have other interpretations in other regions, but also it is also it's again exactly the reason of a program like this is not just the regulation, not just the law in place or the legislative framework in place, it's how it is interpreted, how it is implemented. And that is a very important aspect. Sorry, because it jumped to the other part of the square, but lack of data sharing culture among healthcare professionals. I can read that. So there's this identified by the stakeholders a persistent lack of data sharing culture among healthcare professionals for several reasons. Because they perceive that health data is owned by these data holders, like, for example, hospitals performing clinical trials, and the whole spirit of EHCS is this data sharing. Like Elena Dragdik from Citra said once, data are nothing unless they are shared. And that is the spirit of the law. And this is how it has to be also moved forward among the stakeholders. There's limited mechanisms for patient and citizen involvement that is set by the players in Catalonia and Spain more broadly. So there are no mechanisms for meaningful patient involvement in data governance. So there's the POP. POP is the patient, the platform of patient organizations in Spain. It's really devoted to this aspect. And then anonymization, because only access limits usefulness of data. And then there's the HDS decree currently allows the access only to anonymized data. So this task of our project flagged this as a limiting value. And for us, a good example with evidence is the idea of this open platform that was put in place in Catalonia as an idea, and that is been implemented also through the open air strategy. That one person that was very active at CatSalud and now it's in the CEO of open air looked at primary care specialists, hospitals, everybody in the whole arena being connected to share this data, putting the patient in the center. So we have a little bit of Q&A. I didn't want to extend my presentation too long, but I just wanted to make sure that we overview a little bit of what happened in Catalonia at that level.